Hi everyone, my name is Samuel Budd from Imperial College London, and today I'll be presenting our paper detecting hypoplastic left heart syndrome in fetal ultrasound via disease-specific atlas maps. Fetal ultrasound screening is a key part of ensuring the ongoing health of fetuses during pregnancy, and the assessment of fetal development and accurate anomaly detection from ultrasound scans are integral in diagnosing potential fetal development issues at the earliest time possible to ensure the best care may be given. During screening, standard plane views are used to acquire images in which key anatomical features may be examined, biometrics extracted, and the diagnosis of developmental issues may be made. And several of these standard views and surrounding frames are used to make the diagnosis of hypoplastic left heart syndrome, or HLHS for short. Antenatal diagnosis of congenital heart diseases such as HLHS have been shown to result in reduced mortality and morbidity of affected infants. But unfortunately, antenatal detection of HLHS is not universal, due to the high level of skill required to make the diagnosis accurately from often noisy and inconsistent ultrasound views. So in this paper, we introduce a novel method for the diagnosis of HLHS from ultrasound images using pathology-robust segmentation. We assess the quality of our segmentations in the downstream task of inferring HLHS status from ventricular areas. From ground truth expert annotations, we evaluate the possible correlation of this approximation to true disease status, known from postnatal outcome records, and compare this correlation to using naive segmentation for area extraction to our proposed method. We extract numerical features from each segmentation in order to classify HLHS versus healthy patients, where each ventricular area is the count of pixels belonging to that class. And we apply two common classification algorithms to the extracted area ratio features. And first, use an L2 regularized class weight balance logistic regression classifier, and secondly, using a Gaussian process classifier based on Laplace approximation. For robust segmentation, we extend the recently proposed Atlas ISTN framework with an additional classification module and corresponding component in the loss function. And to the best of our knowledge, we present for the first time a segmentation network that is able to jointly segment, register, and build a labelled atlas that focuses on relevant features to robustly diagnose HLHS for fetal four-chamber views and provide interpretable features known to sonographers. We compare several methods for segmentation by average dice score achieved and show that each of the compared methods is effective for the segmentation of anatomical structures. But the question remains, which method produces the most informative segmentation for downstream disease diagnostics? Our area ratios classification method achieves state-of-the-art performance for HLHS classification over previous classification methods, and the performance of area ratios extracted from automated segmentations is on par with those extracted from expert manual segmentations. The addition of a disease condition branch to the Atlas ISTN improves classification performance over both expert segmentations and previous segmentation methods. Our confusion matrices highlight the improved sensitivity and fewer false negatives of Atlas ISTNs with disease conditioning branches over expert segmentations and other segmentation methods. And our method provides greater interpretability by producing a segmentation and a disease-specific atlas for free. Our results show that automated segmentation methods are on par with human-generated annotations for the accurate identification of HLHS patients, possibly due to more consistent automated segmentation results that aid the linear classification models, in contrast to the predicting from ground truth segmentations, which have been generated by different observers. A limitation of our study is that we require input images that resemble a four-chamber acquisition orientation in a healthy subject, and this can be challenging for severely affected patients. However, for these cases, manual detection of CHD would likely be trivial at the point of care, without segmentation analysis. For this work, we rigidly aligned all the data to a canonical orientation relative to the heart, and observed that this data curation step had a significant impact on all models' performances compared to unaligned images. But this step could also be performed by automated methods. Another limitation is that we do not consider the inherent spatiotemporal information of ultrasound imaging, where experienced fetal cardiologists can derive valuable secondary information from how the heart moves, and this knowledge can inform future work on the topic. Finally, in the clinical practice, still images are common practice to report and document cases. Thus, a direct application to retrospective quality control and diagnosis support for primary care is in reach. Thank you for listening.